So hopefully you can all see that. So it's a bit of a strange environment talking to yourself for 15 minutes, but there we go. So yeah, my name's Corrine. Just for those of you who might not be familiar with the Diabetic Eye Screening Programme in the UK, it goes under the acronym DESP. This was something which was set up in 2003 for the kind of standardising of grading and management of diabetic retinopathy. There are presently 53 services in the UK, and every year, every diabetic over the age of 12, with the exception of those who might be under the hospital, are invited for a routine screening appointment. And at this appointment, they'd have some photographs taken of the back of their eye, and these are then assessed and graded by a sort of grader at a later stage. And in addition to the standard screening programme, the service also provides something called a digital surveillance pathway. And this is something for the management of patients who are perhaps slightly more at risk. So they may see the screening team maybe every 3 or 6 months instead. And there's also a slit lamp biomicroscopy clinic, which is for people who perhaps can't have the photos either because of cataracts or, you know, they can't get on the machine, etc. And so that's how the programme is sort of set up at the moment. And as I said, it's set up for the monitoring and grading of diabetic retinopathy. Now, this is a chronic progressive disease of the retinal blood vessels. And in particular, the subtype of retinopathy that I'm interested in is diabetic macular edema. And this is the swelling or thickening of the central retina, of the macular area, which is characterized by these exudative sort of plaques, these yellow plaques that you can perhaps see on the screen sort of here. And also you tend to get leakage of fluid, both in the inner retina layers and sometimes underneath the retina as well. And of particular interest again is a subtype of DMO, which is subclinical diabetic macular edema. And this is where you have the presence of thickening or fluid at the macula, but it's not visible clinically. So if you were to look through an ophthalmoscope or perhaps down a slit lamp or on a two-dimensional fundus photo, you can't actually see the presence of fluid, but it is there and it is visible using other technologies such as optical coherence tomography. So the current criteria that DESP use for identifying and grading macular edema are on screen now. So as I said, on a photograph, it's very difficult to actually see the presence of fluid or thickening. So they tend to use these biomarkers, and in particular, the biomarker that they like to use is the presence of exudates. And in addition to exudates, also the presence of microaneurysms or hemorrhages within 1 disc diameter of the centre of the fovea, but the vision has to be 6/12 or worse. So interestingly, somewhere between 23 and 40% of patients who do have evidence of macular edema on an OCT scan, in other words, there is thickening or fluid, they actually do only have hemorrhages or microaneurysms. So in other words, they don't have any exudates present. And this is interesting from the point of view of this study, because as you'll come on hopefully to discover, my interest was whether you have patients attending for routine sight tests who perhaps don't have any exudates and have good vision, so they would pass the screening criteria, but they might then go on to have an eye test and have an OCT scan and are then found to have evidence of macular edema. And that was really the rationale for this study. So what would optometrists actually do to manage those patients? Earlier this year, around about June, DESP brought out some guidance for the use of OCT. So OCT at the moment is not currently included as standard in the screening service, but some digital surveillance pathways do use OCT and they have it available. So DESP have brought out some guidelines just to try and standardise the grading, if you like, of OCT findings. And they've also mentioned now that hospitalised services can discharge stable patients back into digital surveillance pathways for monitoring with OCT. So how does this kind of fit into primary care optometry? As I mentioned just earlier, you know, optometrists now are increasingly investing in OCT, or optical coherence tomography, and it's certainly in Specsavers alone this year. I think they claimed over 700 of their stores would have this technology available. So as I said, you're going to get this scenario sometimes where diabetic patients could attend screening. It might have been 11 months earlier and things could have changed, or, you know, they might actually have passed the screening criteria, particularly if their screening service doesn't have an OCT. But then have findings when they actually attend for their sight test. In terms of guidance from the College of Optometrists, the guidelines at the moment just state that we don't need to dilate patients for the purpose of detecting retinopathy as long as they are attending screening. And we should also clarify as much as we can and report all relevant findings to whoever is responsible for the overall care. Now, for those of you who work in practice, I'm sure you would agree that this is not always very straightforward, particularly dealing with certain members of the public. But, you know, it's also a little bit vague. I mean, it's difficult to know who is exactly responsible for the overall care. And I think a particular note, there's no clear guidance on the management of these patients and what we should or shouldn't do, particularly given that the screening service is sort of also, you know, responsible for the care. So in terms of the patients, they've got this slightly unusual scenario going on where they're attending for their routine sight test with their optometrists. They're also attending for their screening appointment every year. They may be under some sort of digital surveillance pathway. Sometimes that's difficult to know. And there's some sort of questionable communication between optometrists and the screening service. But both of these teams do have a responsibility to look after the patient and to refer to the hospital if necessary. So the aim of the current study was to ask a number of optometrists how they would manage diabetic patients who attend for a routine sight test who have evidence of mild or subclinical macular edema on their OCT scan. In terms of the design of the survey, this was done in sort of, you know, thinking about the screening criteria and the positive identifiable referral criteria for maculopathy, which I sort of showed you earlier on the screen. But the sort of area that I was particularly interested, as I said, was these patients who have microaneurysms or hemorrhages, but perhaps maybe have vision better than 612. And may also have, you know, some evidence of macular edema, because they could have, as I say, got through the screening process and not been referred, but then could have findings on an OCT scan. And in terms of the guidance that came out this year, the classifications of maculopathy by OCT findings are on the screen here. And there is a central classification of OCT borderline. And these are people who have evidence of thickening or intraretinal cysts on their scan, but they are not actually eligible for referral at that point in time. So these, again, are people who would have passed the screening test and wouldn't be referred, and could potentially, you know, attend for a routine sight test. So the survey was designed in 3 parts. There was initially some introductory questions, just asking about experience with OCT and training. This was followed by some Likert scale questions, you know, various scenarios, and I was just asking whether they would agree or disagree with the statement. And then there were some case scenarios. The survey was conducted electronically through Google Forms. All of the questions were mandatory, so they didn't have an option to miss out a question. And it was distributed through 53 local optometric committees in England, who emailed them out to their committee members. We obtained consent, but we kept the responses anonymous just to try and encourage people to be as honest as possible. And the survey was open for 1 calendar month. All of the case scenarios, and there were 6 in total, had a similar sort of blurb, if you like, at the start, which was just to introduce the idea that the patient was diabetic, they were attending for a routine eye test, they may or may not have had some mild symptoms, but their vision was always better than 612. They'd always had screening within the last 12 months, and the screening was always reported to be mild or stable with no further treatment required. And there was no exudates or cotton wool spots in the macular area. And then we showed an image of an OCT scan, and we asked what the patient management would be. There was 95 responses to the survey. Around 78% reported having an OCT. Now, I appreciate this is probably not indicative of how many optometrists in the UK have an OCT. I think perhaps people who were responding to the survey had a particular interest in OCT, but that doesn't bother me too much, because obviously it's these practitioners who, you know, would potentially be picking up these types of findings. So I think from that point of view, you know, they're the ones I'm quite interested in. And in terms of training, there was a bit of a mixture of experience. So we allowed people to select more than 1 training option in terms of their experience. So that's why the numbers don't add up to 95. but the majority had had some sort of face-to-face or online CET training or attended a course. But interestingly, around a fifth of participants said that they'd had no official training, and around about a third said they'd used unofficial online methods such as YouTube or Google. We asked about self-rated confidence in assessing diabetic macular OCT scans, and not surprisingly, I think most people were a bit on the fence. We had a median of 3, so they were neither confident or not, but yeah, generally sort of spread around the median, there. But only about 9.5% actually said that they were extremely confident. So perhaps there's some room for improvement in the future. Just due to time, I'm not going to go through every single question, but just to give you a flavour of one of the kind of Likert type questions I asked, I said, you know, if you detect any amount of intraretinal fluid on a macular OCT scan, I should refer the patient regardless of whether they have symptoms. And then the practitioners stated whether they agreed or not. Quite a broad mix of response here. I think you could argue that, you know, pretty much a sort of straight across the board mix of responses. But interestingly, there was about a quarter of participants said that they strongly agreed with that statement, that they would refer regardless of symptoms if they detected any amount of fluid. So finally, just going to go through a couple of the case scenarios just to explain, you know, how they ran. So as I said, there was some presenting text and then an image. So this is an example of one of the case scenarios. So here we have a OCT scan through the central fovea area. There's no loss of foveal contour, there's no obvious thickening, but we do have an intraretinal cyst quite centrally. And in terms of management, these were the results. So we did give an option of other, and I haven't put that on here, but when we stated other, we asked them to sort of, the participants to specify what that would be, and that incidentally actually allowed us to categorise into these 4 options. So around about 60% said they would not refer this patient, which is fair enough, but about 15% said that they would. A further sort of 17% said they'd phone the hospital for advice, and then around 10% said they would phone the screening programme for advice. So I'm not here to say what's right or wrong, that is, you know, each individual person's discretion, but under the DESP criteria, this patient would be classified as OCT borderline, so they would not actually be referred, they would just be kept under the screening programme for surveillance. Second scenario is a patient who's previously had laser treatment and is now stable. So the presenting text explained all of this. They've been discharged from the hospital. They've been to the screening, and the screening programme said they were stable and didn't require treatment. There's no exudates, but you can see on the on-fast scan some little white dots, which is actually just laser scars. And the results are as follows. So about 55% said they wouldn't refer this patient, but about a fifth of practitioners actually would refer this person back to the hospital. We've got about 14% saying they'd phone the hospital for advice and 12% saying they would phone the screening service. So this is an example of somebody who could quite easily be under the digital surveillance pathway. So, you know, it could be useful in this scenario for optometrists to communicate with DESP to find out whether they're under that pathway. Because if they are already under that service, then they probably don't need re-referring, but they could actually just have their appointment brought earlier, for example, you know, or you could at least liaise with the screening service to discuss them. And then just finally is the third scenario. So this was a patient with a large central cyst and some thickening and loss of foveal contour. So in this particular instance, nearly 40% said that they would refer this patient, but interestingly, about a third of practitioners said that they would not refer the patient, but they might monitor them in practice. Got about another quarter saying they'd phone the hospital for advice, but only 5% now saying they would phone DESP. As I said, we had a category of other, which in this particular instance, one person didn't actually state what they would do, so that's why that's on the screen. But by the DESP criteria, this is somebody who would be OCT positive, so the screening programme would actually refer this patient to the hospital. So just in conclusion, there appears to be quite a broad range of management decisions amongst optometrists. This isn't surprising to me, but it's interesting to actually see it, you know, on paper, if you like. But management's not always in line with the current DESP referral criteria, so there is a bit of a mixed bag. in terms of the sort of plans that optometrists would provide and what DESP would provide. More optometrists tend to choose to contact the hospital before contacting DESP, so perhaps the communication with optometrists and DESP isn't maybe as good as it could be, and this leads to potential for increased referrals to the hospital and increased workload through optometrist queries, having to answer the phone perhaps or emails, etc. I think the take-home message is that there's perhaps a need for additional guidance on the management of these patients. And also, as I said, communication could perhaps improve between DESP and community practitioners. And increased training amongst optometrists might also help to improve their confidence in interpreting these scans. Just want to thank my collaborators, Charlotte Hazel and Chris Davey, and also thank you to Professor Peter Scanlon, who's the clinical lead for DESP, for his advice on the project. And I'd be happy to take any questions.
Great, thanks very much, Corrine. That was lovely and really nicely presented. So there have been a few questions that have been typed into the Q&A. So I'll just start from the top and work my way down, if that's okay with you. So the first one is there a minimum pupil size that is needed for fundus photography, which is done by the diabetic eye screening service?
So the screening service would dilate patients, so they always use mydretic drops to dilate the pupils. So I don't think they could standardise the size of pupil size, if you like. But it's just as wide a visual field view as, or a wider view as you can obtain, really.
Okay, perfect, thank you. Okay, so if it is mild at the time of screening, is there always a risk to the patient, or is there a chance it will spontaneously resolve?
Good question. So obviously, for those of you who are perhaps familiar with the way diabetic macular edema works, I work in a hospital clinic looking after these patients. The majority, and I think there is further research to be done in this area, and it's something that I hope to do once COVID is perhaps on a slightly in a better place. But I think for the majority of subclinical patients, they will remain subclinical, so that there's no immediate risk to their vision, there's no immediate risk to the macula. I think that the longer that they've had the fluid and the changes, obviously the greater the risk then becomes for visual loss. But according to the current research, approximately a third of patients who have subclinical edema will go on to have clinically significant, and that's been shown in a couple of different papers. So about 30% of subclinical cases, and it depends on your definition of subclinical, I appreciate, but around about a third will go on to have a significant change, either requiring treatment or hospital referral.
Okay, great, thank you. So whenever the optometrist said that they would have referred, was there a general urgency that they might have stated how quickly that would have been referred to the hospital?
Sure, yeah, there's a mixture. So again, just because of time, I didn't go into the nitty gritty of every response that we gave as an option, but we gave 2 survey options, which was to review in 6 months or to review in a year, and I've just lumped those together as not refer but would review. And a lot of people did tick other, but then when I actually looked at their comments, it did actually fall into these other 4 categories. And they tended to mix, you know, sorry, getting my words mixed up. They tended to see them either somewhere between a month to 3 months or 6 months or 12. So again, it was quite a mixture of opinion, really. And I did wonder how that kind of works with the BCOVS sight tests, because for those of you who are aware, diabetics are entitled to a free eye test every year on the NHS. And as far as I'm aware, as long as you conduct a full sight test, you probably can monitor them for certain changes, but I don't know how generous GOS would be in terms of how frequently, because the other thing about diabetic macular edema is it doesn't just crop up and then go away and that's it. You know, it's a chronic condition, it grumbles along. One day you could have, you know, significant findings, the next day they might have got, well, maybe not the next day, but, you know, that they would then get better and then get worse. And you know, there's certainly, you know, a mixture of scenarios, if you like, in terms of the management of edema.
Okay, great. That's super. There's a few more questions in the chat there, but maybe if you want to touch base with some people afterwards.
Yeah, absolutely, no problem.
Well, that's super. Thank you again, Corrine. That was really lovely.